Good afternoon, everybody. On behalf of Hetero Healthcare, I, Dr. Prashant Kandeparkar, welcome you to this webinar on this troubleshooting PCOS. Doctors, as you know, in Hetero, we market products in multiple therapy areas like in gynecology, dermatology, orthopedics, pulmonology, etc. With a very strong R&D support, we have developed many unique formulations and combinations, keeping patient benefit in mind. Our endeavor is to develop products, formulations, combination which will improve patient compliance and ultimately clinical outcome. We have developed NSAID patches, reverse ligament patches to improve patient compliance. At Frenza, gynecology, obstetrics, and IVF is an important therapy segment for us. We market products for vaginal health like Feminora, Pellitra, etc. We have formulated and introduced a vaginal film containing lactic acid. Doctors, in oral formulation, besides Didropal and other products, we market Mylotin, which is a unique nutraceutical for PCOS management. Mylotin contains myoinositol, D-chiroinositol in the ratio of 40:1, chromium picolinate and melatonin along with folic acid and vitamin D. To speak more about PCOS and management with nutraceuticals, we have Dr. Abhay Sukhatme with us today. Dr. Abhay Sukhatme is MD Gynec Obstetrics from BJ Medical Pune. Sir has 34 years of experience and has expertise in NDVH. Sir is past president Nashik Obstetrics Society, has an active participation in both state and national conferences. Dr. Sukhatme has received IMA Lifetime Achievement Award, is trustee and managing committee member in Symbiosis Pune, a famous national and international institute. Sir is trustee in Arogya Seva Sangh, Ayurveda College, Nasik. I welcome you, Dr. Abhay Sukhatme. The session is all yours. Thank you, sir. Welcome once again.
Thank you, Dr. Prashant. May I know all the doctors have joined or not? Other doctors have joined?
Yeah. They must have joined because we will not. Yeah, we can start.
Should we go ahead?
Yes.
Okay.
Sir, Dr. Abhay, can you speak a bit loudly? Can't hear you. The volume is very low.
That's what was the
main problem.
Yeah. Are you able to?
My apologies. Let's not interfere because
Okay.
his volume is that much only.
Okay, fine.
My laptop has got highest that much of volume. I think it should suffice.
No worries, doctor. But before you start, take a pause of around 4 seconds, then start talking so that I can cut all this talk.
Okay. Good evening, everyone. I am extremely thankful to Hetero Pharma and Dr. Prashant. The topic given to me is a troubleshooting PCOS. Now, to speak about the PCOS is extremely difficult. The PCOS topic has been widely discussed in all the conferences all over India, in local societies, worldwide too. In a dramatic way, I can say, कहना क्या है, सुनना क्या है, कहने सुनने की कोई बात ही नहीं. Everyone knows everything about the PCOS, as the audience are all learned gynecologists from across the Maharashtra. What to tell about the PCOS to all those learned gynecologists? But I think every time you visit any medical topic, or rather revisit any medical chapter or topic, you get something new. You get something newer input. And then we think, Arecha, ये तो कभी सोचा ही नहीं था. This has got that angle too. Oh, very good. And this happens not only with a medical topic, but with any good novel, any good article, any atheist books like Bhagavad Gita, or any popular like Meghdut. You read more and more, you get more and more different inputs every time you read. You get some newer input. Or be it a movie like Oppenheimer, I saw 2 times. Second time I got a newer inputs about the movie. So though it is a very common topic, the more you read, you definitely are bound to get something new. I am sure I am not going to go and repeat what has been known to you about the PCOS. Some common topics like definition, characteristics, symptoms, I will like to skip, and I will like to focus more on a newer molecule or more on a newer inputs about the PCOS. I do remember PCOS was initially during our student days, PG days, was described as a Steen-Leventhal syndrome, diagnosed by the scientist, name itself suggestive of Steen-Leventhal. And that doctor has approached or given a different view to this disease, saying that this is the commonest cause of infertility, and the treatment he recommended was a wedge resection of an ovary. And surprisingly, that was working, but the basic principle in his suggestion of a surgery was reducing the stromal content of ovary naturally means reducing the androgenic content. Now, that has been sophisticated way performed in today's world by the laparoscopic ovarian drilling. So initially, this PCOS, it was more concentrated or focused in initial days on an ovulation. Slowly, as we advance, the people realize it's a more complex disease. There are multiple symptoms. It is no more a disease, it is a syndrome. Patients do have hirsutism. They have some reproductive problems. They have some obesity. They have some insulin resistance. And surprisingly, in today's world, every 1 in 5 women is suffering from PCOS. That's a huge number. If you say 20%, that figure doesn't make any impact. If you say 1 in 5 women, that is it gives a good impact how much the severity of this syndrome is there. I do remember, this is a typical picture of Steen-Leventhal, what I described, the originator of this concept. Here, the ovarian volume is extremely important. He emphasized was given on ovarian volume, a volume greater than 10 ml or 10 cc, with only one ovary, has estimated that it must be having 10 small cysts, which are ranging from 2 to 9 millimeter. And later on, in the Rotterdam's criteria, this antral follicle count was taken into the consideration. Usually, this disease is diagnosed only when patient gets symptom, either menstrual symptoms or cosmetic symptoms or metabolic symptoms. I won't go into the details of these. These are something extremely important: reproductive, metabolic, and psychological too. And this is a cascade of what can affect the PCOS. There is an environmental factor, there is a genetic predisposition, there is a gut dysbiosis, and there is a lifestyle also. Lifestyle do have an impact on PCOS. And nowadays, PCOS is considered as a lifestyle disorder. That means it is never going to get cured. You have to have a change in your lifestyle in order to suppress the PCOS. The S itself is suggestive of a syndrome complex of this nature, where there is a hormonal imbalance, there is hyperandrogenism, and there is an insulin resistance. I do remember in initial my days of a practice, way back 30 years, when we used to prescribe the metformin as a treatment for in the PCOS, the patient, whenever used to go to the chemist used to say, "Oh my God, your doctor has given antidiabetic drug." And the patient used to get confused so much that either he used to return to us in a fighting mood or he used to change the doctor. And surprisingly, they used to believe the pharmacist rather than the gynecologist. Nowadays, everyone knows metformin is being used in the treatment of PCOS, and thanks to Google also, which is also educating the patient regarding this, all various drugs which are in use of PCOS. After that, this was the criteria, and Rotterdam's criteria was defined in 2003, but the more logically accepted now is the androgen excess PCOS criteria, whether either there should be criteria A or B, or one of the either B or C. A is a must, that means clinical or biochemical signs of hyperandrogenism, and patient can have either oligo or an ovulation or polycystic ovarian morphology without any other endocrinopathies. This is the all diagnostic criteria that has been defined for the PCOS. I won't go into the details of the clinical hyperandrogenism, more defined, more known for practically all patients: acne, alopecia, ovulatory menstrual dysfunction, polycystic ovaries, and whatnot and whatnot. The main focus now was shifted towards the last decade or last 2 decades was on the insulin resistance. And this insulin resistance has been found to be the key role in the metabolic syndrome of PCOS, and the treatment addressing the insulin resistance has proved beneficial in the patients of PCOS, adolescent PCOS, either those who are in need of a fertility or they are having other cosmetic symptoms. The insulin sensitizers played a major role in the treatment of PCOS. Initially, the PCOS in a fertile childbearing age group was focused more with the drugs which were of a ovulation induction category only. Slowly, as the ovulation induction drugs along with the insulin sensitizers were added, there was a result which showed that there was an improvement in the success rate as far as the fertility is considered, pregnancy is considered, when you are using the ovulation inducing drugs along with the insulin sensitizers rather than using alone ovulation induction drugs. Now, why this insulin resistance happens? This is a complex hormonal play. There is not only HPO axis play or disturbances, but there in between adrenals is there, ovaries are there, and there is a peripheral adipose tissue. And all this can lead to the dyslipidemia, increase in the sugar level, increase in the LDL, and elevated HDL cholesterol. So naturally, it becomes the multiple things are involving, we label it as a syndrome. But suspected patients of a PCOS, as we said in the definition, there should not be any other endocrinopathies, meaning that there should not be any thyroid or prolactin interference or increase or abnormal levels. When these levels are normal, then only we say that it is a PCOS. The commonest cause of this in the childbearing patients, which leads to the infertility, and that figure is about 40%. And the main reason there is, as everyone knows, there is altered LH upon FSH ratio, which leads to the increased androgen production, thereby causing the decrease in the FSH production, and thereby causing the follicle impairment of a follicle maturation. So all these hormonal cascade or basket needs to be investigated in the patients of PCOS. Now, what are the goals of the treatment? Now, naturally, goals varies with the age of the patient you need to have regulation of the cycle. You need to improve the insulin sensitivity. You need to reduce the weight. You need to improve the fertility or conception rate. And of course, the androgen, which is the culprit, needs to be the issue of increase or hyperandrogenism should be addressed properly. This is something, and this was more in the COVID. The COVID was an emergency, so no one was knowing which drugs to use. This drug has come, people tried with this result, they got the result. Somebody tried another drug, they got the result. Then later on, they came to know that this is not a proper protocol. This does, but it was accepted in the COVID as far as you are giving the result. But proper monitoring and protocol needs to be addressed for a disease like PCOS, which is going to be there for years to come because of various changes in the lifestyle of a younger generation. And then we will need to address various issues like lean PCOS, PCOS leading to the infertility, obese PCOS, where there is a hyperinsulinemia and where there is a extreme hormonal imbalance, increased altered LH upon FSH ratio, there is a hyperandrogenism. Only correction of PCOS will be there in the lean PCOS. For infertility, we have to correct the PCOS as well as we have to give the patient conception, thereby aiming her or targeting the ovulation phenomenon to occur in a very successful way. Obese patient, they have got a different issue. As we know, the lateral or peripheral adipose tissue is a main culprit which aggravates the PCOS because there is a peripheral conversion of androgen into the estrogen in peripheral fats. This increased estrogen level leading to the hyperestrogenemia, aggravating the PCOS. PCOS again aggravating the obesity, as we see the in the previous slide, dyslipidemia, and again obesity leading to the PCOS. That is a vicious cycle. So there is nothing a magic formulation which is a complete. Now we came across a various formulation, and a newer drug has come into the existence, and the newer drug has been tried variously. I was surprised that initially I would like to go some in a lateral way, keeping aside the PCOS. When some around 4 to 5 years back, one of the pharma company came with a formulation of a melatonin. I was surprised that melatonin is a very good sleep inducer. Why I can't use melatonin, this drug, for inducing a sleep in a females, especially with a PMT syndrome and with a menopausal syndrome. I will appeal to the pharma company to look into this matter. I have used this drug in the PMT syndrome and perimenopausal symptoms very successfully in initially 4 to 5 years. Later on, I shifted it to the ovulation induction drug. It's a wonderful drug. And I know I was aware of this drug because my son was in the USA and his colleagues, those who were the US residents, the family people of his friends were taking melatonin tablets regularly as a sleep inducers because there this tablet was available as a dietary supplement. And this drug was not causing the addiction. That was the beauty of these drugs. But melatonin, this drug is a really wonderful drug, secreted in the night by the pineal gland. And as you know, nowadays, the females working overnight in the BPOs, in the IT industry, lack of sleep, lack of that darkness is not there. This pineal gland dysfunctions are bound to be there. And that may be the reason, one of the reason of increasing PCOS incidence in those IT segment females. The concentration of PCOS in the pre-ovulatory follicles is much higher than that of plasma, which shows that there is a direct effect of ovarian function of the melatonin. So this melatonin, along with the myoinositol, DCI, chromium, and vitamin D3 and folic acid, everyone knows it's a very good combination which helps or assists or addresses the issues of insulin sensitization. This is a combination of a myoinositol and D-chiroinositol in a physiological ratio as a 40:1 available in multiple brands should be treated as a first-line approach in the PCOS patients when you have to address the insulin sensitization issue or insulin resistance issue. I think there is a various studies addressing or showing that the PCOS, myoinositol and folic acid, there is a highly probable chances of increased ratio of success rate as far as the treatment of PCOS and the infertility is considered. Chromium is a micronutrient and combined with the picolinate, which increases the gut absorption. Surprisingly, in initial stages, when we use the probiotics, we also found an increasing result or success rate in the PCOS patient. And now gut dysbiosis is coming in a major way in the PCOS. I think this is going to be one more drug which is going to change the scenario, additive drugs, not the solo drugs, along with all established drugs like MI, DI, melatonin, and some gut dysbiotic drugs which are bound to change the scenario of PCOS and will be used for those patients also who are not desirous of fertility. And there is various studies which shows that the metformin versus chromium picolinate was tried, and it was shown that effectivity or efficacy wise both may be the same, but tolerance, as far as the tolerance is considered, chromium was considered to be better tolerated than the metformin in the management of PCOS. Now, this is a melatonin is a wonder drug. As I have told already, this is secreted by the pineal gland, and surprisingly, this drug levels were found to be higher. Serum levels were found to be higher in the PCOS patients. But in fact, there is a contradiction to it is that melatonin levels intrafollicular were much less in the PCOS patient, and that was the culprit. And the reason of this decreased melatonin in the intrafollicular graphene follicles of ovaries, which is the cause to have an increase in the melatonin serum levels of the PCOS patients. And the very fact itself detects that melatonin intrafollicular has got some role in the ovarian or follicle maturation and ovulation. And I have gone through the literature which says that testosterone and estrogen do influence the melatonin production, and castrated rats, they show their lower melatonin. This contradiction, like various altered blood levels, this is there in the PCOS patient with the hyperandrogenemia. Like in the PCOS patients have the hyperandrogenemia, but if we look at the level of intrafollicles, the androgen levels are less, because the reason of androgen level is less because androgens are converted intrafollically into the estrogen or estradiol, which leads to the hyperestrogenic condition and leads to the PCOS. And naturally, the drugs which act at this level are bound to be beneficial, and this drug at this level means aromatase inhibitors. The melatonin, these drugs in PCOS has got acts on a multiple level. It has got a metabolic function. It enhances the ovarian function. There is a relationship between the glucose homeostasis and insulin with the melatonin. In fact, melatonin helps in or improves the glucose homeostasis, improves endothelial vascular function, thereby addresses the issue of IGF factors, suppresses the hepatic gluconeogenesis, and optimization of glucose levels at the muscles, skeletal muscles. There is one more interesting thing about the melatonin, that it inhibits the androgen to estrogen conversion in the Graafian follicle. This is something like it is acting as a selective estrogen receptor modulator, SERMs drugs, and selective enzyme estrogen enzyme modulators. Letrozole is also SERM. That means these drugs act like estrogen, where estrogen is needed, for example, endometrium, and it acts as an anti-estrogen where estrogen is not needed, like breast and other tissue. So it's like an aromatase inhibition, acts like aromatase inhibition, and therefore anti-estrogenic activity at selective levels reduces the obesity, promotes the follicle maturation and ovulation, and helps in affects the or improves the ovarian microenvironment, thereby improving the insulin resistance. And these various studies like melatonin in the PCOS along with the myo-inositol or DCI-MI combination along with the folic acid and vitamin D3, that helps quite a lot in the PCOS patient. And there one more study, as we observe that if at all PCOS patients conceives, there are high chances that they land up in the misabortions. And usually the reason for this is that there are reduced number of implantation sites and there is a higher collagen content in the uterine horns, which inhibits or hinders blastocyst endometrial reactions, thereby reducing the implantation sites. Somewhere I have read that melatonin as a co-treatment along with other insulin sensitizer shows improvement in all those implantation sites, thereby increasing the chances of live birth rate along with its antioxidant property. I think I have come to the end. I think that should suffice about the newer drug which has been addressed to the various issues of the PCOS. I think it has been addressed up to the mark, and the newer molecule, I think I have tried to give the justice as far as possible. Thank you, Dr. Prashant.
Thank you, sir. Thank you very much. It was I mean, as you say, in every session you learn something. For me, this learning is the prevalence of PCOS in IT related, ladies, very interesting, this thing with melatonin not being secreted because of darkness, etc., etc. Lovely insights. You really learn something with each webinar. Doctor, there have been a few questions.
Okay.
Like in which type of PCOS would you prefer this type of formulation? Like we know, or reproductive, metabolic, psychological, or even lean or obese?
In all patients, it's an insulin. Basically, it's insulin sensitizers.
Okay.
It has got the metabolic activity also. It has got the anti-androgenic activity also. So it helps in cosmetic, regulation of the menses, addresses the metabolic issue, addresses the insulin resistance issue, irrespective of. And basically, it is a very high safety profile without any side effect, without dependence.
Absolutely. That's very important. Safety tolerance is very important. Generally, are these PCOS age-related? Like in young patient, you get a particular type of PCOS. I mean, this is more of an academic question. Or in a little elderly, you get different type of PCOS, or it doesn't, any type of PCOS any patient can get.
Younger means if you want to categorize the age from 11 to 16, I won't label those patients as a PCOS.
Okay.
Because their HPO axis is not mature.
Absolutely, yes.
Yeah.
Yes.
unless and until there are some cosmetic changes.
Okay.
Cosmetic changes says that or points toward that there is a definitely hormonal disturbances where cause may be the ovarian origin.
Okay.
Other than that, there is no other endocrinopathy. So that patient we have to look very careful. Otherwise, up to the 16 years of age, we should try to avoid the level of PCOS in these patients. When the axis matures, then we can go as per the criteria and label the patient whether she has got PCOS label, because labeling the disease is something which is a very its own trauma.
Correct. Well, a lot is spoken about the ratio of myo-inositol and D-chiro-inositol, 40:1. What is your opinion, really, sir?
It is well studied and proved to be very beneficial.
Yes, exactly. And about melatonin.
Addition is these are all dietary products. Myo-inositol and DI and these are available on in the USA as a dietary supplements.
Correct. These are physiological
physiological.
ingredients. Yes.
So physiological are usually harmless.
Correct. And what do you feel about this? I mean, this melatonin, we have said about melatonin, chromium anti-inflammatory effect and insulin resistance effect on cysts is also very well proved.
Yeah, anti-inflammatory is also very well.
Yes. And even effect on insulin resistance is also, I suppose, chromium is very well studied. Generally, how long you would prescribe this product?
No, for infertility patients, still she conceives.
6 months.
Still she conceives. I am going to try these drugs, melatonin, in first trimester of pregnancy also. Okay. Because implantation, there is something which issue.
Yes.
It also helps in implantation. Yes. But I want certain proofs about the safety of melatonin in first trimester of because some other gynecologists should not suppose.
That's correct. That's correct.
I mean, studying all those materials, proving or giving me the result, it's safe in the first trimester of pregnancy.
And for long-term use, have you experienced any adverse effect or
no?
No. And I mean, it's very difficult to say. How soon is the patient response?
Usually within 3 months.
Usually within 3 months. Okay. And would this product make sense in before IVF procedure, 2-3 months before prescribing this product? Before IVF procedure?
IVF should be the last resort.
Yeah. That's correct. Anyway, thank you so much, sir. This has been all from my side. And thank you for this wonderful insights,
Thank you.
Yes.
Thanks a lot.
And I thank all the participating doctors who took time from their busy schedule and commitments and attended this webinar. Thanks, marketing team Hitro, for conceptualizing and organizing this webinar. As you all will agree with me, this type of program requires a lot of hard work and ground coordination. Thank you, Hitro field personnel, for a super coordination. Last but not the least, thank you, IT team Hitro, for your support and guidance in all technology-related matters. Once again, thanks to all of you. Wishing you a very pleasant evening and signing off. Thank you.